question now that's on the floor.
Okay. I'll let them handle that part. Yeah, but I don't want to like project it on having two things. Oh. So I'm really glad to see how many. Shows up when folks are seeing healthcare providers. Can you hear me okay right now? Some, okay. I want you to realize that if you're not very familiar with some of this stuff, me asking you to think about these things differently might make you uncomfortable. Okay, so kind of pay attention to that for yourself, to figure out like where you have some edges where you need to grow a little bit, so that you can be a more effective provider when you're working with folks in the community. And if you do get uncomfortable, I'm just going to ask you to give yourself permission for that, because figuring this stuff out is a developmental and learning process. You know, and sometimes the hardest part is figuring out where we are in the process and what we are and are not comfortable with. Okay, so give yourself some grace. And I'm happy to talk with people afterward if anybody wants to check it. So the state of Michigan is now requiring most licensed professionals to undergo implicit bias training. So implicit bias is kind of more dangerous than explicit bias because it's the kind that we're not always aware that we're carrying and that we're acting on. In general, this is a pretty unconscious thing that we act out. Partly because we haven't been exposed to things, partly because we're maybe not comfortable, we don't have the knowledge that we need. So then we really have to kind of pay attention to what we're doing in the world. And so again, that's partly why I'm asking you to like think about how you feel, notice when you're uncomfortable, so you can figure out where some of your growing edges are. What happens with implicit bias is that when that shows up in doctors' offices, for example, then people are not comfortable actually sharing what's going on with them, sharing who they are, what their issues are, and a lot of times folks, especially if they identify as trans or gender non-conforming, might not come back for the care that they need. So then it becomes a barrier for people getting health care. So stereotypes, I hope we all know about, right? And because our brains take in so much information every day, those get activated really quickly because our brains are looking for shortcuts, right? Our brains are like, I'm taking in too much. How can I quickly make sense of what I'm seeing in front of me? And that's when stereotypes will come into play. And sometimes we can recognize those when they happen for us, right? It's like, I can be like, oh, I'm responding to a stereotype in my head, and then I can choose to change how I'm responding. The implicit ones are the harder ones, because I might not be aware of what I'm doing in the moment. It might hit me later that I'm like, oh, that feeling was actually about how this person presents. And I might be able to figure that out at a different point in time. But in the moment, it may impact how I'm relating to the person. So that's why we have to be paying attention to these things. Have any of you done the training project Implicit through Harvard? So they have a really interesting training that they've been testing for years that helps you understand what some of your implicit biases are. So you can sign up for that, take that test, and figure out where your biases are and how they land. And that's a really good way to kind of get started with this. If you're interested to understand what your biases are, you can go to that website and you can take the trainings on sexuality and gender. There's one specific to transgender populations, and that will help you understand how you score on this test. Because this test really is measuring how quickly you respond to things, which means if I'm taking more time because I'm stopping and going, ooh, I don't want to respond in that way, that's going to impact my response time on the test, and that's how they're measuring the implicit bias. So it's a useful thing to do. Mostly, I really want you to develop some awareness around these issues today, since a lot of folks, if you're not part of this community, you may not have the inside information or be comfortable talking about it. And the Gender and Women's Studies Department here at Western, they have a motto, don't believe everything you think. And I think this is a really good way of getting at some of that implicit bias stuff and how it impacts us. So if I have an immediate thought about a person that I'm going to see for services, I want to check myself and go, hey, don't believe that. That's probably brain noise. And that might impact them how I'm going to interact with that person. So for example, I don't know if any of you have ever had the experience where you see somebody in the world and you can't identify their gender right away. And like, even me, who works in this field, there have been times when I'm like, I realize that like 20, 30 minutes later, I'm still thinking about that person, and I'm like, why do you care? I don't know that person. Why do I care what their gender identity is? Why do I need to know? But I think it's part of what our brains are doing automatically. So that's just one way that it kind of shows up in the world. So if you have something like that coming up, you know, just pay attention and help develop your awareness about it. So what we're engaged in as professionals in healthcare fields is these relationships with clients where we are held to ethical codes of how we're supposed to be treating them. So one of our jobs is to raise our consciousness around what our own biases are and how those might impact our clients, and to become more self-aware. So by you showing up for this today, I think you're making a good contribution to this effort. And then as you learn more, then you know how to be more effective in terms of what interventions you're offering. Consciousness raising is kind of hard work. And one of the things that happens is, in order to really understand areas in which we have privilege and other people don't, we have to listen to the people who don't have privilege so they can tell us how it shows up in the world. It takes practice. We need to expose ourselves to more things. So even though I work in this field, and I have relationships with young people who are non-binary or have different types of trans identities, I still struggle with pronoun usage sometimes. Okay, because it's like I've had 60 years of learning how to identify people with pronouns, and so I still have to sometimes apologize and then use the correct pronoun for folks. So know that it's not like you're just going to get this automatically. But what I do appreciate is, like, I have a nephew who's 8, and when my mom misgenders my trans son, my nephew would be like, oh, no, Grandma. No, that's him. It's he, him. So that's encouraging to me that little kids are able to do this much more easily than we are, because they haven't been socialized as long. So if you do get access to this later, we can make this available to you. But I know one term I think would be important for us to know about is polyamory. Is everybody aware of polyamory in this room? We need to be aware and conscious of that, because a lot of people are practicing these types of relationships now. So if we're talking with people about their relationships and we don't have awareness of polyamory and how frequently it happens, then we're not going to be asking the correct questions to make sure people get the care they need. Okay, so here's one case for us to start with. Kiara identifies as Latinx and bisexual. She's in the waiting room for her OB/GYN appointment, and she's looking through informational pamphlets. She's disappointed to see few people of color on the pamphlets, and all the couples are portrayed as heterosexual. So Latinx is a gender-neutral term. And in any case, I wouldn't use this term unless the person uses it to describe themselves. So we're always going to be looking to the people to be the experts in their own life experience. So I wouldn't assume Latinx, but Kiara has identified as Latinx. Does that make sense so far? Mm-hmm. Okay, so why is she disappointed with what she saw? Any ideas? Yes?
She doesn't feel represented.
Yeah, she doesn't feel represented. The waiting room environment has made her identity invisible. She is not reflected in anything. So this is a really good thing for us to be aware of. Like what's available in the waiting rooms? What kind of folks are represented or not? What can the office do to make sure people feel included? There's a couple of pretty simple things that the office can do. One is like thinking about what's being displayed and who is represented. Is everybody there? And that includes people's abilities, disabilities, as well as gender identity and sexual orientation, okay? Offering at least one all-gender bathroom. Because, you might not necessarily want to out yourself when you go to the doctor, but you just have to go to the bathroom. Right? And you may not always feel safe depending on who's in the setting with you. Does your agency have policies for non-discrimination against folks who have these identities? And what's the language look like in the forms that your office is using? Do you ask people about their gender in terms of what gender they were assigned at birth, and if they identify with that? And if not, what gender do they identify with? That's an easy way to start thinking about how inclusive are we really being here. Okay, let's talk about Ebony for a second. Ebony feels out of place arriving for her neurology appointment because the medical assistant addressed her as third when she was checking in. This is not uncommon because of her short hair, but it's also upsetting. While in the waiting room, she hears staff behind the counter talking about someone they know who grew up in a bad live area, but later married into a really good family. She becomes even more distraught because the neighborhood the staff is discussing is near where she lives. So what's contributing to Ebony's distress in this situation?
Misgendering.
So yeah, Ebony has been misgendered. That's always difficult, especially if folks already have some type of gender dysphoria that they're experiencing. She may also have been experiencing bias because of her race. There may be a whole bunch of stigma that she's walking into that setting with already, that she's experienced from previous visits. And because of the neighborhood where she grew up, and that being identified by the workers in the office in a way that doesn't feel very inclusive, and it is stigmatizing you, then she's been put on alert that she might be experiencing some mistreatment. So it's really kind of activated a bunch of previous microaggressions and experiences that she's already had in life. So at this point, how open is she going to be able to be with her provider when she finally gets to see the provider? Because what we know about our bodies is that our stress kind of shut down, right? So if I'm starting to shut down, I'm going to be much less likely to be open with my provider to say what I need. So one way that we can help is to train staff to use gender-neutral terms. To speak respectfully about people because we don't know how much they can overhear. And I think especially since we live in this time of so much media, we get used to watching people having discussions, right? Because we watch people doing things on our phones and in movies all the time. So thinking that somebody might be overhearing what we're saying and being aware of how that might impact our clients is going to be really important. Because, again, this can lead to people being excluded from care or deciding they don't feel safe enough to go back. So I did some recent research with some colleagues here in the college about folks with trans and trans-expansive identities and how they access health care. And there's a lot of ways in which they feel excluded. So you really want to think about what we're saying, what kind of assumptions we're making, and then how that's conveying who's welcome and who's not. So some gender-neutral responses that we can use. Instead of saying, can I help you, sir, ma'am, or miss, we can just say, how can I help you? Okay, just get rid of that section. How are you guys or girls? This is what I continually work on because I use guys all the time. But that is a gendered term. So I've been really trying to change how I'm related to that. Instead, how are you all doing? How is everyone? You can say folks, you can say students. You can use a lot of different terminology, but you have to practice it to get more comfortable using that. Instead of saying, can you ask him if he's checked in? Can you ask if they've checked in? Can you ask the patient if they've checked in? The APA in their publication manual has started to say, in terms of grammar, we can use they as a singular. So if the APA is making that in terms of academic writing, I think it's pretty safe to say that we should be doing that when we're speaking as well. Because that's an easy way to be inclusive. And instead of saying thank you, dear, or honey, that's really not acceptable anymore. You just say thank you. Okay? So in the scenarios that we've talked about so far, what were some of the assumptions that were being made about those clients as they were coming in? They were assuming gender, right? Because she had really short hair, they called her him. And also assuming that everybody who was coming in is heterosexual and cisgender. I just included the ethical principles from the NASW since I'm a social worker, and I know that the other professions have similar expectations of us in terms of being culturally competent and not discriminating against our clients. But it's just a good reason to think about why it's important for us to do this. This is a way to make everybody feel included and make sure that we're helping them be respected and get the care that they need. And in social work, we're responsible for making sure that we are doing advocacy work for folks who are in marginalized groups already, which includes sexual orientation and gender identity discussion. So part why I'm talking about this population is the National Institutes of Health recognized several years ago that sexual and gender minorities are a health disparity population, which means that their healthcare needs are not being met the same way other people's are. So then it's good because then they can fund research, they can do more education around it. But this is partly why we need to pay attention, because these types of exclusionary experiences for this population make it harder for them to access care. So I moved here from Fond du Lac, Wisconsin. And when I was still in Wisconsin, people would tell me about going to the doctor and the doctor saying, oh, we don't treat people like you if they had any type of trans identity. And I can't imagine like how does that fit with our codes of ethics? And how can we like tell somebody we don't treat you? It's like, okay, you're not an alien species. I mean, we should have knowledge to be able to treat you. So then it becomes more about like my internal issues tell me I don't have to. And I think that's a problem. So I'm assuming that you have some awareness of terminologies for people's identities. Do we know what LGBTQ plus means? Does anybody need help with any of those? The plus is just a way to be more inclusive. You could, sometimes we include A for asexual. The Q can be queer or questioning. I don't particularly like the sexual and gender minority language, but since it's coming out of the National Institutes of Health, and they're trying to make research be more applicable, I try to use that one. Because I would really say it's more about folks being minoritized versus them being minorities. Do you understand the difference in that? The difference in being minoritized versus being minorities? They're minoritized because of the way people in society treat them. So, when I'm meeting with somebody, I'm going to identify myself, which I should have done at the beginning of this, I apologize. So, I'm Melinda McCormick. I identify as a woman, cisgender woman, and pansexual. I'm part of the queer community. I have a trans kid, and my pronouns are she and her. So, if I'm working with me and taking notes, what are the pronouns? What am I going to use? And in some doctor's offices, they actually ask these things so that they know how to properly address folks that they're working with. But I think what's really important is to understand you need to use the language people are using for themselves. And I would be really careful about what you read online, because I was teaching from a textbook the other day where they were using the term transvestite. And I was like, oh no, that's really dated. No. Unless somebody tells me that's my identity, I'm not going to use that term. And we really have to be aware of like who we're working with, because like for some people my age, they will not use the word queer. Whereas for me, that's a political identity, and I'm really happy to use that. And plus, I like to say queer instead of doing the whole word salad thing. It's a shortcut for me. But we have to pay attention to how people are responding to the language, and we can, it's okay to really ask them. What language would you like me to use? What pronouns would you like me to use when I talk to you? One reason that we put this in our signatures on our emails is just to let people know that we understand that not everybody identifies with whatever gender they were assigned at birth. So one of the things I want you to think about is how do you make space for your clients or patients to let them share information about their identities with you? Are there particular questions that you ask? What kind of language do you use? Is that something you've even considered? Our culture makes a lot of assumptions about sex. We want to think that it's binary, that it's an either or. But researchers have been looking at gender for a long time. And Anne Fausto Sterling once said there should be at least 5. least. So we've really kind of fallen into this, it's kind of a trap, I think, to think that there's only one or another. Because, again, our brains are tired. We want things to be more simple, but that's not how people's identities really are. Because most people are cisgender and heterosexual, that's what we assume everybody is. And that's kind of been codified into a lot of laws and procedures in our society. So in academia, we talk about this idea as heteronormativity. We expect that everybody is heterosexual and cisgender. So do we understand cisgender? I didn't define that. Okay, so cisgender just means you identify with the gender that was assigned to you at birth. Okay? So our systems, like around marriage, adoptions, have been really structured around this idea of heteronormativity, right? So that it's easy for straight people to get married. It wasn't until 16, 15 that queer people could get married. Okay, so that took a long time for that kind of equity and parity to happen. But then our systems are also set up with this particular lens. So pay attention the next time you have to fill out a form to see what are the gender options. And one of the things that really bothers me is if they included other. Because in sociological theory, other people is making them less than. So I'm like, so you say, mine isn't listed here, and then you ask them to fill in what's missing. I think it's important to be aware that younger generations are seeing sexuality more as fluid, with the idea that this can change over your lifetime, and that sometimes you feel this way and sometimes you feel that way. There are some researchers that are now talking about being hetero-flexible or homo-flexible. And sometimes people just don't put all of that into their identities. They're just like, I have sex with who I want to have sex with. I'm attracted to who I'm attracted to. But we're starting to understand much more that it's not necessarily a really fixed identity for folks. And I think what's interesting really is to see how younger people are starting to do this, like kids. You know, I have several friends who are like, oh no, my kid told me when they were 3 that, you know, I'm he and I want you to call me this. So in some ways, young people are kind of pushing us to grow in understanding around these areas instead of being stuck in these old binaries that don't work for everything. And researchers are starting to acknowledge more often that this is a normal variation in sexuality and gender expression. I think before we kind of got hung up on statistical normality and kind of added a moral piece to it. Instead of just saying these folks don't exist as frequently, we decided that there was something morally wrong with them if they were not representing themselves in that way. So here are just a few newer pronouns. Sometimes they're called neo-pronouns. I still hear new ones every day. Recently I read a book that was more trans-centered. It was like set in the future, some like young adult novel. And they used one I hadn't heard of, but it helped me so much to read it in a book repeatedly. Okay, you go, oh, okay. It helps to see it in writing and to see it being used, to hear people using it, because then it makes our brains start to pick up on it a little bit. So the NIH came out with a document on guidelines for pronoun usage in the workplace, because they're noticing that this is impacting people's health and well-being. Because when you use somebody's pronouns that they use, you are affirming their gender identity and who they are. It shows mutual respect, which is really important. and it creates a more welcoming environment. If you have coworkers who are purposefully misgendering you, and not using the proper pronouns, that creates a hostile work environment. And so for government agencies, you could have some repercussions for treating folks that way. But I also think, like, to be just decent human beings, I can afford to work with my discomfort around pronoun use to recognize somebody else and who they are. Especially if I know that that's going to cause them a lot of harm. If I don't. Are we all familiar with intersectionality and how this operates in society? So one of the things that's going on is like people have many more identities than folks used to have. The landscape in America is changing. How we identify ourselves is changing as well. And so for those who have privileged identities in our society, privilege just means we treat people differently based on certain identities that they have, right? You don't get flagged for being a heterosexual or able-bodied in our society. Whereas the more of these identities that you have that are under that bar, that shows domination, the more at risk you become in general across all areas of society because of how people treat you, because of assumptions that people are making. So privilege is hard to see because if you have it, it's not really very visible to you. But when you don't have it, then you really see it. So, like one question that I've asked before to think about heterosexual privilege is, can you assume when you go home to a family event that your partner is also invited? Or is that something that you're going to have to get special permission for? That's an easy way to think of heterosexual privilege. How about cisgender privilege? Anybody think of some good examples of that one? How about if I tell you my name, you take what I say? And you don't say, oh, but what's your real name? Or maybe I can go to the bathroom without people asking me what I'm doing in that bathroom. And then I'm really supposed to be there. So those of us in this room have a certain amount of privilege just by the fact that we're here. Right? And so it's important for us to understand what ours are, how those impact how we receive the world and the clients that we're interacting with. Because if I'm not aware of them, then I might be kind of thoughtless in my responses to people. And also, we all have ways in which we're not privileged, right? So it's not like just because I'm a white woman, my life is all great. You know, we still have issues that we all have to deal with, right? But my race isn't an issue that I have to deal with in most cases. Like I can assume when I'm at the airport, pretty easy for me to just walk on through. So because of how society has seen folks with LGBTQ plus identities, they might face a lot more oppression and discrimination based on that. It might be harder for them to get jobs, places to live. And then they might be folks of color as well, which adds another layer of discrimination and oppression that they have to experience in the world. So it's just important to have some awareness of this for yourself and for who you're working with. And one thing I want you to be aware of too is, like, you don't have to identify as part of the LGBTQ plus community to be discriminated against. Because if you present yourself in a certain way, people are going to make assumptions about you, and you might experience discrimination just based on that. Can you take that thing off the screen for me?
Oh gosh.
What was that up here? of multiple marginalized identities. We're at risk for poor outcomes in life, okay? Minority stress theory says this is something that as you experience this over time, it's a cumulative effect that it has on your health and well-being. Schuster, who was here last year for the Bill Bergen lecture, says that it can result in discrimination, invalidation, and one of the biggest problems is a lack of education in providers. Because a lot of times folks who are trans are going to be educating their providers on what kind of care they need because they're not getting enough training in the field before they enter it. And that's a pretty big burden on someone, to have to be able to go in and tell your doctor, actually, this is what I need. I wish you had this training and I wish I didn't have to educate you to get my needs met. So we know from work on social determinants of health as well, that over time, this is going to lead to poor health outcomes and early death. So that becomes even more important that we figure out a way to deal with this so folks can have better health outcomes. So here's a couple of things that you can do to try to help you in terms of how you're dealing with folks. Focus on the specifics about the individual in front of you. Try not to rely on stereotypes or not make assumptions based on what you see. And try to take that person's perspective. What might it be like for this person to see you for the first time? What might they be bringing with them from previous experiences that you need to try to help them overcome? One thing that's helpful to consider, I think, is what are my initial reactions in clients, especially if they're different from me in some way. Do I notice that I have some initial thing inside me that's getting activated? Doesn't matter what it is. I just want to pay attention to it, so that I'm not acting from that in a way that might be harmful to my relationship with the person I'm working with. And I also think it's important to reflect afterwards. What am I learning about myself from working with clients that are different from me and that somehow have challenged me in terms of thinking about who I am as a provider? Because that extra step that's called praxis. It's like, what am I learning? How can I reflect on this? What is this going to teach me so that I can do a better job moving forward? And I think it's important too to think about what kind of barriers people might have to receive care when I'm working with folks. How have their interactions with larger systems of oppression especially, impacted their ability to be able to show up and ask for help here? And are there things that I can do in the community to help with some of this? So like for me, doing these types of workshops is a way that I can help. Because I want folks to be able to show up for care and feel like they can get treatment and not be invalidated or disrespected. Okay, I don't have a watch on. How are we doing time-wise?
It's 11:42.
Okay, so I got a little more time. Let's look at another case scenario, because I think these are helpful. So Aria arrives for an urgent care appointment and appreciates that the person at the front desk asked for the name she goes by and her pronouns. She's disappointed later, however, when the nurse practitioner asks if she has a boyfriend while taking a sexual health history. So there's a couple of ways in which assumptions got in the way of this relationship already. The first assumption is that she dates men, right? That's heteronormativity. She presents as female, she must date men. She's also assuming that she only has one sexual partner. Whereas, in fact, this client has multiple partners, which include women and men. So then, this might make Aria feel like she can't really talk about what her sexual history is like with this provider already, because the provider has shown that she's coming from that heteronormative viewpoint, and so is Aria going to be judged when she's like, no, I have multiple partners of both genders. So a different way that they could have asked that question is, are you sexually active, and could you describe your partners? That's not making assumptions. That's asking for information. So then she can disclose those things and feel more open about it. Then the practitioner could ask her to describe the types of sexual activities she engages in with her partners. Because I want to make sure that this client's getting the testing and the screening that she needs for her sexual health. Sorry, I got distracted with the deer up there. That's cool. But does this make sense to you? Asking these questions just a little bit differently can create space for people to be there with different identities. And so then they don't feel automatically excluded and like they may experience discrimination if they share who they actually are. Selena is a transgender woman who is being examined for an infection in her hand. The nurse has never taken care of a transgender person before and finds himself really curious. He catches himself staring at her repeatedly. While taking her vitals, the nurse asks, at first I thought you were a real woman. Do you take hormones? Have you had the surgery yet? So what kind of assumptions are those?
Yeah, real.
I'm sorry?
What makes up a real person?
Yeah, what makes you real? Do you take hormones? Is that any of your business in this situation? That's like your curiosity, not something you need to care at that moment. Right? If that person's there for a hand infection. And have you had the surgery yet? That's assuming that everybody who is transgender has surgeries, which is not the case. People decide what to do with their genders on the whole spectrum of ways. Some people just do social transitions. So that's making another big assumption. And then the client has to say, I don't think that has to do anything with my hand. It's like, why are you none of my business? Is this your business in that situation? It's like, I get that we're curious, but is that respectful? My son saw a doctor in town who had recently had some training on working with trans folks. And when my son came out, he was like, oh, you people need blah, blah, blah. And hey, do you know so-and-so? And my kid was like calling me from the waiting room, going, Mom! It's like outing people. We don't out people without their permission. And then that whole you people thing. So it's like enough information to be dangerous, but not really sensitive. So these were pretty big microaggressions that Selena experienced, right? Especially that real woman did. That would make me want to smack someone. Honestly. So do you think Selena's going to want to go back to that provider? Oh heck no. If I'm Selena, I'm going and I'm telling all my friends, do not go to this provider because it's not safe for your care. So think about the questions that you're asking. Is it because I'm curious or does it relate to what's happening here? As a woman of science, I get this all the time when I go for medical care. Right? The first thing out of some doctor's mouths is going to be something about my weight. I'm like, thanks, I'm sick right now. Can you help me with that? So it's not just this situation. So I think it's important to just think about some of the assumptions that we're making when we're questioning folks. We can let people know that we don't have a lot of experience. And we can also apologize to people if we make mistakes. If you make an authentic apology, most people are willing to accept that and move forward. But if you don't make it, then you don't have a chance to repair any of that relationship. So you could say, I'm sorry for my mistake, I didn't mean to offend you. I think you should apologize for asking questions that weren't relevant to what was happening in the moment. And, being taken away by this curiosity, because I'm like, you can take your curiosity to Google. Okay? That's what Google's for. There are lots of ways that you can do that without alienating people. But I think it's like, don't be afraid to ask questions, but like try to remain open and curious. That can do a lot and authentic. I think this is the last case I've got. This is Dawood. Dawood is meeting his pregnant wife, Imran, at the health center for a prenatal appointment with the midwife. Dawood is transgender and is in the process of transitioning from female to male. The midwife, along with the midwife in training, enters the room and sees Dawood. The midwife says to Dawood, "Hi, you must be Imran's sister. It's nice to meet you." Dawood, upset, responds, "No, I'm her husband." The midwife looks startled and mumbles, "Oh, sorry." The trainee notices that Dawood and Imran are visibly uncomfortable, but the trainee doesn't say anything. So the midwife assumed Dawood's gender based on his presentation. And that was hurtful because that's not how he identifies. This also showed some heteronormative bias in that the midwife made the assumption that Dawood was Imran's sister. So with this going on, Dawood feels invisible, uncomfortable, unwelcome in this situation. So the midwife could have just said, "Hi, nice to meet you. Tell me what's your name and what is your relationship to each other?" So same kind of question, but not making the assumption. And this can be hard, like the trainee was probably uncomfortable, but how do you correct someone who's in charge of you? But I think we're not trained very well on how to correct folks around this stuff in general. So, if you feel safe, you can follow up with the person later. And I have a few ways to help you talk to folks when they're making biased comments. Always using I statements and trying to come from a place of empathy and maybe assuming that the person doesn't know better. We want to help people save face if we want them to stay in a relationship with us. Sometimes I'm going to talk about the difference between the person's intention and the impact that their statements had on the client. Right? Okay, you didn't intend to. I can accept that. At the same time, what you said really impacted that person, and they're probably not going to come back here. So that part matters. So we need to think about being kind and respectful, and how to provide culturally competent services to folks who differ from us. So here are just some samples of things that you can say when people are making jokes, statements. Just letting them know that, like, sometimes I might just say, "Oh, you know what? I'm really not okay with that. I see this a little differently. And I prefer if you use this language instead." Or I might just be informative. I might just practice some psychoeducation. "Oh, actually, that terminology is really out of date. We don't use transvestite anymore. Unless the person tells you that's their identity, you need to ask them their identity and use what language they use." Better language I've learned to use in this situation is, so sometimes as students going into the fields, you're coming with more newer knowledge than some of the folks who've been there a long time have. So you do get a little bit of leeway. You say, "Oh, actually, let me ask you about this because we learned this, and this is what I'm seeing here. So what should I really be doing?" stop and have questions?
I would stop and have questions.
Okay, so does anybody have questions that they would like me to answer? Again, I'm so appreciative that you came out for this. I hope you got something useful out of it. Happy to share the PowerPoint with you later if you want to look at some of that stuff. I took most of it from an existing booklet from Fenway Health in Boston.
All right.
Thank you.
Well, we thank you so much for attending. Please know that Dr. McCormick is right here in this building. And so you can always stop by her office or send her an email and check in with her. You are welcome to ask her questions individually. I'd like to introduce you to our interim dean of the College of Health and Human Services, Dr. Jennifer Harrison.
Hi.
And she I don't see it. She left. Okay. Thank you for coming. Happy holidays. We'll see you in January for the next one.